welcome to the Westin MCAT podcast with your host, Ahmed
and Eric Olson.
Welcome back, everyone, to another episode of the Westin MCAT podcast with Ahmed and Eric. Today, we're going to be looking at this concept of socialization and what it means to experience horizontal or vertical mobility, and, very interestingly, how that connects to the practice of medicine. And so I'm excited to hear a lot of what Eric has to say today. As per usual, before we dive in, Eric, how's your residency? I know you're several weeks now into the derm.
Yeah, I'm like 10 days into it, but I missed a couple of days because I was on vacation, so I've only really
right.
this. Actually, had an interesting day today. We had the opportunity to they do a week of dermatology here in their second year of medical school at the school year.
Oh, okay.
And I guess as part of Derm Week, they have some of the dermatology residents come and talk through some cases and talk about a relevant disease process. And so I went and did some teaching on it was on a disease that's not exactly my favorite, which is lupus.
Okay.
Because it's just really complicated, and we didn't have all that much time. We had 10 or 15 minutes per group, and lupus is a super complicated disease, and there's a lot that goes on with it and a lot to know. But anyway, it was fun. It was fun to I felt like I knew something,
Yeah. Well, I was gonna say I could see you being, excited, and I could see you thriving in that sort of mentor teaching kind of role.
Yeah. Like I was saying, it just wasn't enough time. I wish I had, an hour with every group so I could really talk to them about, so I could really field their questions and really see, if they had questions about lupus or if they had questions about medical school or residency or anything like that.
Yeah.
Because you hit the nail on the head. Those are things that I enjoy. Obviously, we do the podcast and that's nice, but it's nice to really get a little bit deeper with an individual or a small group, as the case may be. But even so, it was nice to be in front of a group of people and teaching about something that I'm passionate about. Albeit, lupus, which I'm maybe less passionate about than some other skin problems.
Right.
But yeah, it was fun. And some of the residents who had done it the last year had said oh yeah, the medical students, they, number one, they'll hang on your every word. So really think about what you're going to say and how you're going to present it and kind of the points you're going to make. And so I felt a responsibility to make it a good session. And then they had also said oh yeah, they'll probably ask some questions that are kind of nitpicky. You really need to know your stuff. Because they've been doing this for, they've been doing this dermatology week for a few days and they've been studying hard. And so they have honed in on some things that might be less familiar to you because you kind of focus on different things as you progress throughout your medical education.
Right.
So I was last night I pulled out step one, or first aid, excuse me. And for our listeners, first aid is a big old textbook study guide for step one, which is the first exam that you take, and it has all the relevant, all the high yield topics and information. So I pulled out first aid and I was reading about lupus and seeing kind of what the important things were from a first, second year medical student perspective. So I was ready to field all those questions, and it was just fun. It was fun. It was a fun time, and you do a decent amount of teaching as a physician. I guess you can make of it what you want, but with your patients, if you really have the time, if you want to make the time, you can sit down with your patients and really talk about the disease process and talk about, different treatment options and benefits and, pros and cons of different treatments, and do some shared decision making and things like that. I think some physicians probably do a better job of that than others.
Yeah.
But it's different, when you're talking to a patient about something like that and the level you have to be on versus the level that you're on when you're talking to a medical student. And this is we'll talk about, socialization and different kind of social strata. But the way that we, or at least I was instructed to talk to patients is talk to patients and kind of teach them on an 8th grade level. That's appropriate, to expect that people will understand things on an 8th grade level. And so that's how you can kind of present information to them. So it's different to be presenting things on kind of a higher a higher level, a more detailed level, a more kind of physiologic level, as we talked about lupus today. Anyway, it was fun.
Yeah. Well, I mean, I feel like there's an element of, it being rewarding too, though, that you get to sort of tailor to a more informed audience.
Yeah.
Sometimes I can feel more impactful in a way, not that it necessarily is, but like it allows you to kind of showcase your expertise a little bit more fully, which is always nice. But I feel you on the point about the patients. We had a clinical skills session, I believe it was last week's, where, the objective was to really emphasize, the this like power dynamic, even between a medical student and a patient, because oftentimes, a patient doesn't know the difference between a medical student and a resident and a resident and a doctor. And, to them, you are, the top of the mountain as a
You're the
medical
provider.
student.
Yeah.
When really, as a medical student, up until now, we've all felt like the very bottom of the totem pole, right?
Yeah.
And, but it's certainly true, like the nuance and the subtlety of interacting with patients and patients of different backgrounds too. And I think that's what we're going to get into today is like, obviously the MCAT applications of socialization, mobility, etc., but how it connects to medicine as well. And I think that's probably a good place to start is like defining socialization. And I think this is one of those words that you can really break down into parts. I've always learned, the ization suffix as the process of
Yeah.
whatever. And
Yeah.
then social is social, right? Like socializing, integrating into society. And so when we put those two things together, socialization is the process of integrating into, society and accepting slash learning, different norms,
Yeah. Yeah.
values, rituals, etc. And I think as far as the MCAT is concerned, our listeners should be aware of, two main types of socialization, primary and secondary. Primary, logically speaking, is going to be the most, forefront or obvious socialization, and that's going to come in the form of like your parents and caretakers, etc. The people that really kind of mold you into who you are. And secondary socialization is sort of an extension of that, looking at, external influences like teachers and friends. I'm sure we can all think back to a teacher that really, made an impact on us and altered our perception of things, etc. That would be a great example of secondary socialization. But I think, the important point here is again, like learning to break up words, right? I think it's like social in general, like, I never knew all the terms. I will never, that will never be my claim to fame. And I, to this day, don't know all the terms or even most of the terms. But I think psych social does really lend itself to, this ability to, break things down and understand what they mean, right? Or at least be able to infer. But
Yeah. Yeah.
uh, from a clinical standpoint, I'm curious, Eric, like how often does someone's cultural background play a not insignificant role in their care?
Honestly, I think the place where I've seen the most like I think obviously like in language is a big one, and that's maybe I don't know. Do we count that as part of culture? Probably.
Yeah, 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 of course.
If a patient comes in and they don't speak the language, then in most settings, in most training settings, hopefully there are mechanisms in place where you can get an interpreter
Right.
either in person or on the phone. During my intern year, we had an in-person interpreter in the emergency department, and so if you and there were Spanish speaking patients coming in all the time, and so if you had a Spanish speaking patient, then you could just say, hey, come here and let's go talk to this patient, which is helpful, but it kind of complicates the process of obtaining information, and hopefully your interpreter is trained in like medical Spanish and things like that. You're
Right.
technically not supposed to use like a family member as an interpreter because you
Yeah.
never know if they're going to kind of change the story. Whereas a
Right.
trained and certified kind of medical interpreter is going to say exactly what you say to the patient, and they're going to say exactly what the patient says back to you. And so there's not that kind of telephone game that's being played.
Right.
But I'm thinking, like the other place where I feel like culture plays into patients obtaining the care that they need is like, and this is just my own experience and kind of what's coming to mind, but like, do you know families, like individuals who come from families that like don't go to the doctor ever? Like,
I feel like, yeah, and again, this is just pure speculation, but I feel like it all comes sort of from like, you know, a overarching like cultural perception of medicine. Like there are certain communities that have historically relied more on like natural sort of medicine,
sure, yeah.
as opposed to, we'll say more modern medicine. I remember when I was shadowing either last summer or 2 summers ago. And we had an East Asian patient who was very against surgery.
Mhm.
Just, the way they sort of grew up, interventional medicine was not really, something they really believed in. And so, the patient ended up opting for things like strength training and diet modification, etc. And so you see it from time to time. I'm sure,
Yeah.
you would know more in that regard than I would at this stage, but definitely something to keep in mind.
Yeah, I mean, I think we often think of like culture playing a role, and not this is not wrong by any means, but like we think about different like parts of the world, right?
Mhm.
But when we talk about socialization, like I think the most powerful agent of socialization is the family, and I think that's
Yes,
that's like an MCAT testable thing, is like the family is
absolutely.
kind of paramount in socialization. And so in my mind, like there's a family culture in a sense that comes along with that. And I'm thinking about my sister-in-law who like never grew up. Not that she's like anti-Western medicine or anything, but she's like, you know, a white American female, has her family's been in the States for like, generations and generations. Um, but like her family just doesn't go to the doctor. And so to me, like I'm thinking about how does culture play a role in like the patients that we treat? And I'm thinking like in a lot of cases, and same thing with my wife's grandmother, like she never went to the doctor. She had bad diabetes. She never went to the doctor. And so I think like in a sense, sometimes it plays a role in like the patients that we don't see. You know what I
Yeah,
mean?
yeah,
Um,
yeah.
and it's interesting, like the way that these things play into the way that medicine is viewed. I'm thinking about there's a book called, have you heard of this book? It's called The Spirit Catches You and You Fall Down.
I haven't. No.
You should talk to Jaden about it, honestly, because he probably read it as, I think, when I was starting med school, or like right after I had been in, before I started med school, maybe. Harvard Medical School was like, that was like required reading for their med students. And
Okay.
it's like a I would say it's a novel. It's like a memoir sort of thing, um, written by this individual who's like talking about the Hmong culture. I don't know if you're
Okay.
familiar with them. But there's like this Hmong community in Southern California, I think is where it's set, or Northern California maybe. And it follows a family, and there's a little girl in the family who has epilepsy.
Okay.
And I guess like the terminology for epilepsy in Hmong, like the words that they use to describe the disease is the spirit catches you and it falls down. And it kind of
I
like
see.
follows their journey of like their interaction with Western medicine. Like they were immigrants, like they didn't speak the language, and they had a hard time like getting integrated into the medical system. And at the same time, their perception of epilepsy is that it's like, and I may be fuzzy on some of the details because I read it like 6 years ago, but I think their perception of epilepsy is that it's not entirely like a disease process, but there's like a spiritual component to it, right? Because when you have a seizure, you like kind of go into this trance-like state, and you can't, like, people can't really communicate with you, right? You're like not really in contact with our physical world, and so there's this perception in the Hmong culture that it's like a trance-like sort of spiritual state. And so it's like, that's their culture and that's their
Right.
understanding of this process. And so like there's kind of this push and pull between like our kind of Western medicine interpretation of the disease versus kind of this cultural interpretation of what's going on. And who's to say that it's not kind of a spiritual experience as well? But it's kind of an interesting interplay, and I think you see those sorts of interactions and those sorts of factors playing a part in a lot of the medicine that we practice. And we'll get into it a little bit more later as well. But I think I think there has been a push in recent years to kind of emphasize that in medical training, and that's, the psych soc like wasn't on the MCAT, a decade ago. Like these are kind
Right.
of new concepts for physicians in training, and I think it speaks to our willingness as a field to like integrate these things that are so important to people's healthcare.
Yeah,
This is like the way people interact with the world and they interact with their own bodies and their health, and so it's good. It's really it's valuable for us to learn about these things as pre-meds and as medical students and moving forward, because it probably has more bearing on a patient's interest and ability to adhere to a medication regimen and adhere to a treatment plan than pretty much anything else. Just their cultural upbringing and kind of their understanding and the way they interact with the system.
100%. And I think, there's so many factors, culture being one of the biggest ones, that sort of dictate, a patient's interaction with the healthcare system. Another one, tends to be socioeconomic status. And I think, it's an unfortunate aspect of, medicine, but, you know, a hospital is as much a treatment facility as it is a business, right? Especially, private hospitals as opposed to, affiliated with institutions and teaching hospitals, things like that. But, it's another sort of aspect of this concept of socialization and stratification where, stratification, the process of being sort of kind of divided into different strata or tiers. People at different levels of, the socioeconomic strata uh, have markedly different health outcomes. And, the literature and the research is not only unanimous, but very, very thorough with respect to, different conditions where, SES plays a big role. And, just even early on in, my exposure to medicine, it's pretty clear, like somebody's financial background plays a really big role in, how, treatment sort of progresses for them. For example, if you want to prescribe a particular antibiotic that needs to be stored at, cold temperatures, right? But your patient doesn't have a working refrigerator,
Yeah.
that's not going to work.
Yep.
And there's countless cases of people not going to the doctor, knowing, the bill that's coming their way if they're uninsured or things of that nature. And I think it's, at least for me, like, you know, go going into medical school, being early in medical school, you have this, I don't want to call it naivety, but it is in a sense, this perception that like you can fix anything, right? Because that's kind of why you want to go into medicine is to fix anything and everything. But slowly you kind of realize that there are these factors that are out of your control that you have to learn to navigate. And, there's like I said, in just my brief experience, there's been a couple of patients where, plan A doesn't work simply just based on the patient's background and status. And so we go to plan B, sometimes even plan C. And it's something that we need to be prepared for as physicians and future physicians, et cetera. I'm curious, does that play, have you seen that play a big role in the scope of your practice, Eric, like a patient's financial background with respect to like how you move forward treatment wise?
Yeah, I mean, well, so a couple of points, and I'm interested to hear, like, and you've kind of touched on your own experiences and perceptions, but I'm interested to hear as well, like, have you guys talked about this in med school, and like, what has that looked like so far? So don't, because I want to hear that, but
Yeah,
I'll first if you want.
noted. Yeah,
Um,
go ahead.
so like, I have a patient who I saw the other day, and I'm like being careful because I don't want to, say anything that I shouldn't.
Yeah,
I have a patient with a disease, and it's like kind of non-specific. We've done some biopsies, and usually you do a biopsy to like really definitively diagnose something,
right.
at least in dermatology.
For
And
our listeners, just for context, a biopsy is when you take out, a piece of living tissue. It's not a huge chunk, but it's enough to evaluate under a microscope. And now you can, identify what the underlying sort of processes and pathologies might be.
yes, beautiful. Thank you, Amma. So in dermatology, many times we'll do either a shave biopsy, which is like when there's, some sort of bump that we want to take off, then we just kind of shave a little piece with a razor blade. Um, and the alternative is called a punch biopsy. I mean, this is
Right.
like, this doesn't matter to you guys, but whatever. We're talking about it. A punch biopsy is where you take, it's like a little cookie cutter, and you take a core of skin about the size of a pencil eraser. And then, you put a stitch in to close the skin back up, and it gives you a little more tissue, and it gets a little bit deeper. And so
Right.
you can examine not only the epidermis, but the dermis and often the subcutaneous fat as well, kind of depending on how deep you get. Anyway, we had done a biopsy and it was kind of non-specific. A lot of times you get a biopsy result, and it's like, it's definitely this. This is the diagnosis. But sometimes, it's not a certainty. So we had tried, over the course of years, this patient had been tried on a number of different medication strategies and things to try to control this skin issue that she had. And nothing was working. And she was very wealthy. And she was like, I'm going to go, thank you guys for your help. I'm going to go across the country and see an expert in this field at, a big center where you have to pay, 10,000, I think some number of thousands of dollars for a consultation. And this person, like the physician they were seeing, is like a super expert, like superhero in dermatology, and like is going to be, I'm sure, very helpful. But like, who is doing that? You know what I mean?
Right.
Like, no
Yeah.
one is doing that unless you have, a few $1,000s to blow on flying somewhere else and then spending on this clinic, right? I think that, and then I'll contrast with another situation, I guess. So much in the United States is controlled by insurance, and it's not, I don't think it's really the same sort of issues that you have in Canada, although I don't know, maybe you could speak to it a little bit more.
Yeah.
But, in the United States, and in dermatology, we use all these medications that are like very expensive biologics and things. There are medications that are cheap and there are medications that are expensive. And when you get into the realm of like injectable medications for psoriasis and for eczema and things, like these are thousands of dollars a month. And it's something that patients can't afford unless their insurance is willing to foot the bill. And so a lot of times your decisions on what kind of treatments you're going to be able to provide someone are based on like whether or not they're insured at all, right? Because if they're not insured, then you're pretty limited. You want to do right by your patient and not bankrupt them, right? And so you try things that are maybe not the absolute best treatment, that are still effective things, but are maybe not what you would initially reach for, in order to try to give them something that would be feasible for them.
Yeah.
And then, not only a question of whether or not they have insurance, but then what insurance do they have? Because that will similarly like dictate. Some insurances are really good and will pay for anything you want. You have to give them a little bit of justification, but they'll kind of bend to your will. Whereas other insurances are really stingy and don't want to do anything. And so it's kind of this complex, like, you don't usually think of it as socioeconomic status, but really this question of insurance is a big one. And we have a free clinic here, or a free clinic for individuals who reside within our county.
Okay.
And so all of those individuals don't have insurance, or none of those individuals have insurance, I guess is how I would phrase it. And so practicing medicine there is just different than practicing medicine at the university, because the patient population is different, the financial means are different, and because we use so many expensive medications, and I guess this is maybe not unique to dermatology, but I think it's a problem that we face a lot, that we have to kind of tailor things based on what is affordable and what is not. And I will say, kind of in conjunction with this conversation, not necessarily financial means, but I guess kind of in a financial sense, like if you have patients who live far away, if you have patients who have difficulty with transportation, if you have patients who, for whatever reason, have difficulty getting to your clinic or keeping their appointments or whatever the case may be, it similarly will kind of influence your decisions on what you can and cannot do for those patients. Because for example, there's some medications that we use that can cause damage to the liver and can cause elevated triglycerides and things, and so you have to do laboratory monitoring. There are other medications we use that are immunosuppressive, right? And so we have to do other laboratory monitoring to make sure they're not getting infections and things. And if you have a patient who misses, 80% of their visits, then you're probably not going to put them on a high risk medication,
Right.
right? And similarly, like maybe that's the best thing for them. But if they can't make it to your clinic, if they don't have a car and the buses are unreliable, then it limits you. You don't want to put your patient in danger. And so
Right.
it's it's an unfortunate reality of the system that we work in. Um, we
Yeah.
wish that there was equitable access to care in every sense to every person in the United States and around the world. Um, but it really does play a major role and make a difference in your treatment strategies and the way you kind of view how you can treat your patients and how you can do best by them. But what have, they kind of providing a few examples of some of the experiences that I've had, and these are just
Yeah.
like these are like in the last 2 or 3 weeks.
Right.
How has it been kind of presented to you in the last few weeks as you guys have talked about things in school?
Yeah, I mean, Canada is a little bit different, and you alluded to that. In at least in Ontario, we have, like free healthcare.
Yeah.
So, basically, and I'm not the most well versed in this, so
Sure.
make sure to, double check me. But a lot of things are covered by the provincial government, and some of the extra things that are not typically are covered by insurance up to like a certain threshold. For example, I remember when I had ACL surgery was covered by healthcare, so
Yeah.
didn't really pay anything for that. And then insurance covered up to 80% of like my custom knee brace that I ended up not opting for. Um, Very, very silly reason. My thought process was somebody sees me wearing a knee brace, they'll know that I've hurt my knee and subsequently target my knee. Not the right thought process, but anyway.
Maybe saved you some further injury though. Who knows?
Yeah, I mean it's actually, not to get too off topic, but the Dawn Joy knee brace specifically, um, at least per recent literature, doesn't really prevent injury
Oh, really?
a whole lot, but mentally it provides a lot of comfort and
Hmm.
security, which I guess has its own merit. But in any case, um, other times, for example, my mom had a kidney transplant covered by the, provincial health care.
Yeah. Yeah.
Whereas in the United States, it's an entirely different ballgame. Like my ACL surgery would have been, a 5-figure operation. My mom's kidney transplant might have been a 6-figure operation. And, it's like you said, it's an unfortunate reality that like if you're not insured, you might not be able to get a kidney.
Yeah.
And, I think it's a very harsh reality that, you kind of have to embrace or, recognize as you move through this sort of journey towards becoming a physician. I'm grateful that in Canada there's, an infrastructure in place where, we're able to help more people, just given sort of the baseline level of, you know, care and such. Granted, every policy and, strategy has pros and cons. So, uh, you know, obviously a huge pro is, the healthcare in Canada, but one of the cons is taxes are much higher, right?
Mm.
Because I I think it's really, really important that people understand like money doesn't just appear, like it comes from somewhere, right? So
Yeah.
like
Yeah.
of course, everybody would love to provide free care to everybody. But if you sort of follow the grapevine, you're going to get to somebody who has a family to feed, right? So, like, you take the kidney transplant, for example. Sure, okay, you get the kidney from the donor, right? Maybe the surgeon is feeling super altruistic and they want to do a pro bono surgery, hypothetically. Okay, cool. You have your nurses, you have your anesthesiologists. Then you also have the hospital who has to pay for
Yeah.
the equipment
The
and the
equipment,
imaging,
yeah.
and all of those things are, they've got to pay, the equipment company, and they've got different, utilities expenses. And so the point being, like, if you follow the grapevine far enough, you're going to reach somebody or some
Somebody
entity
has to get
that
paid.
needs to get paid.
Sorry to cut in, but just briefly,
Yeah, yeah,
like I think people don't understand as well, and you alluded to this earlier, but like as much as we don't want medicine to be a business, like a hospital needs money to like run so that it can provide services at all to anyone,
yeah,
right? Like if you were doing everything for free at a hospital, then you would go bankrupt and then the hospital would close and like all the services it's providing to a community would not be able to be provided to that community, right? So,
right.
I think there are definitely lots of problems, but like not everything can be free, and I think
Yeah,
we don't have a perfect system by any means, but I think like we have to understand that there is like we need the hospital to stay open, I guess is my perspective. And so
yeah,
like
yeah.
we have to like make some money to like make it so that hospitals exist, then I think that's we could improve on the way that it is, but I think it is a necessity, right?
I agree. And the one of the hospitals that I'm at for my first year, for context, I'm at like my university has what they call academies, which are like these sort of subgroups within, the university of like different clinical sites
Mm,
that you sort of rotate between. And so my academy is pretty cool because you get put at multiple different hospitals. One of them is sort of more of a community hospital. It's, a little bit out of the downtown core. And they recently got like a $50 million donation. And, to the maybe uninformed, passerby, $50 million, like that's gonna change everything for this hospital. When really it's like, and not to say that this is what the money was used for at the hospital, but like in reality, like that's just a transplant wing, or
yeah,
and
it's a
don't get me
small,
wrong,
yeah.
transplant wing is a very, very major addition potentially, but it's because of major donations like that in large part that hospitals are able to function. Granted, in Canada there's a lot of taxpayer money that goes into
Mm,
funding the healthcare system, like the upper and not to get too much into like the politics of it, but like the upper tax bracket, I think is getting taxed in the realm of like 53%,
yeah,
which is a lot.
pretty high, pretty high.
And
But
they're, as far as it pertains to doctors, actually, there's some recent controversy in Canada with respect to capital gains tax, which, for those that don't know, capital gains are when you make an investment, the profit you make on that investment is called a capital gain. So whether that's stock market or properties or, etc. And so the Canadian federal government implemented a policy recently that basically changed your capital gains tax from 50% to two-thirds over $250,000, which basically means, say you have a cottage, right? You bought the cottage, 20 years ago for 350 grand. Now it's worth, 850 grand. Your capital gain is $500,000.
sure, yeah, yeah.
The first 250,000, can't remember what they're taxed at, but everything above 250,000 used to be, you would report 50% of that as income, and the other
Mhm.
50% you just keep.
Okay,
Now you report two-thirds of that 250,
67%.
which is
Yeah,
going to get taxed at like 53%. And so
yeah, yeah.
the outcome of that, actually, believe it or not, is doctors have been leaving Canada.
Really?
Yeah. And so not, to the point of like, the collapse of the healthcare system or anything like that, but like many doctors have contemplated leaving the country because, a lot of their, resources are allocated into different investments. And, you know, it's wild to think about how like that type of policy, which is seemingly unrelated with anything to do medicine, right, can actually impact, your healthcare system. And it ties back to this idea that, money has to come from somewhere. And so the rationale behind this, elevated capital gains tax is, well, okay, we want, the wealthiest in the country to do just a little bit more, which sounds fair. But then the downstream consequence of that is now you're incentivizing the wealthy to leave. And
Yeah.
those wealthy are, your cream of the crop lawyers and doctors and pharmacists and pilots. And so I think, we've kind of strayed a little bit from the MCAT, but I think it's an important lesson. Like, just always think in terms of like, what are the consequences? And especially when you guys interview, I think this applies to interviews as well. Like, when you get a question, like, you know, don't just, throw out, for example, if you get like a dilemma, right? It's so easy to say, like, oh, I'm going to resolve this issue completely by doing X, Y, and Z. But like, you also have to factor in like the realities of X, Y, and Z. Like, I remember when I was prepping, I had an interview question that was, your hospital hasn't received as much, funding as anticipated from donors, et cetera. You've got, X number of patients whose care collectively costs some number Y, which is bigger than your budget. What do you do? And so the easy answer is, oh, I'm going to go find the missing whatever money. But like,
Yeah. Okay. Great answer.
and it's unfortunately just not that simple. But
Yeah.
the topic of money though lends nicely into this idea of horizontal and vertical mobility. And I think it's a really cool concept because, for a little bit of context, my family has experienced some vertical mobility over the past 20 years. And basically what that means, vertical mobility means moving up in strata. Horizontal mobility means moving within the same strata. So for
Hmm.
example, horizontal mobility could be, you go from being, a criminal defense attorney to a prosecutor, right? Or you go from being a nurse to a pharmacist, you make a career change,
Yeah.
right?
Mhm.
Something where you're still relatively within the same stratum. And, obviously I'm just over generalizing here. Obviously, if you go from an entry level nurse to the head pharmacist, that might be upward mobility, but notwithstanding. But so yeah, anyway, for context, like, I grew up in Midwest United States. My dad was getting his PhD at the time, and my mom was working. I actually don't even remember what her job title was, but it was very, very entry level position at some bank in the city. And I remember I didn't even like it sounds wild to me, especially when I compare myself to my sister who, is far more spoiled than I was. But like we lived in this like student dorm at Purdue University where it was a small two-bedroom apartment and you know all the neighbors, I guess you would call them, were quite, fascinating people in more ways than one. Um, but I remember living, there and like my source of entertainment, I'll never forget this, for my sixth birthday. My mom's colleague got me a Game Boy, which was like a big thing back in the day.
Yeah. For sure.
And it had like three games, one of which I think was like Mario Kart, and I was over the moon. And now my sister like will just like she has a MacBook for school and like which like granted like she's using it for educational purposes as well, but like I think just like reflecting on sort of how my life has played out kind of helps me appreciate this idea of vertical mobility where my dad finished his PhD and he got a good job and
Yeah.
then I was able to find my own job. And so, but, it's again important context in medicine as well, because, I think one of the underrated powers of medicine is actually with respect to mobility, like the ability to help patients actually experience upward mobility, right? Like if somebody has a really debilitating condition, right, you're able to, alleviate, treat, or even go as far as to cure said condition, you give them their quality of life back. And now, that they can regain that
They
motility
have more
again.
capacity. Yeah.
And I think like, I was reading, was reading a case study not too long ago. It was a patient with um, a benign brain tumor. And I can't remember what it was called, but basically it was causing, just this, out of sorts balance and, irregular movement. I think it was maybe pressing on the cerebellum. And so this was a construction worker who, over time this tumor had developed. They could not work.
Mhm.
And so eventually, they had the tumor removed and, with treatment and therapy and such, got back to their job and eventually, ended up ascending within their construction company. And, it's a great feel-good story. Uh, and I think I try to focus on that side of medicine more so than the insurance side of medicine, just
Yeah.
because it's so much more comforting.
Why wouldn't
But
you? Yeah.
I'm curious, like, can you think of any stories like that, Eric, where like you've had a patient come in and their treatment really maybe changed their trajectory outside of like health, like with respect to work or anything like that?
I don't know if I have had that experience. I
Fair
think
enough.
like what are those I feel like those fields are going to be like surgical fields,
Right.
like
Sure.
neurosurgery for sure. Orthopedics I think is one where like people are unable to use their limbs and you fix
Right.
something and then they can use their limb, right? I think there are some pretty debilitating diseases in dermatology, but there are things that are not quite as easily, not that surgery is easy, but not quite as quickly fixed.
Right.
So it's kind of more of a process of trying to get someone back to where they want to be.
With
Um,
derm, it's probably more, would it be safe to say it's more systemic rather than localized if you've got like a
yeah,
pretty serious derm condition?
yeah. I mean, anything that's going to be debilitating is going to be systemic, unless you have like a bad wound or an ulcer or something like that that's not healing. I mean, there are things that are localized. I should take that back. But again, like usually things that are maybe a little bit harder to get under control.
Yeah.
Um, I did want to touch briefly, kind of branching off from what you're talking about, with the like vertical and horizontal mobility conversation.
Mhm.
And again, maybe this is more of like a United States centric point of view, but I think that like in the US, there's like a narrative about I'm trying to think of like who it was that talked about that, like what US president talked about pulling themselves up by their bootstraps. It was like someone used to say that. Someone
Sounds
president.
like an FDR or a Theo Roosevelt
It
kind
might
of
have been
quote.
Theo Roosevelt thing. But so, like there's this idea in America of in the United States, excuse me, of like oh you're down on your luck and like you're gonna like start working harder and like make it, like the American dream, right? Like
Yeah, yeah.
you start from nothing and you like work your way up, or whatever. And I think like, that's it's not like disconnected from reality. Like that happens, right? But I think our understanding of social mobility is a little bit different from that, from like a data driven perspective.
Yeah.
I think we adhere, and again, like there are certainly lots of instances of that. Like there are instances of vertical mobility that certainly happens all the time. Um, the idea of social reproduction, though, I think is an important one to be familiar with,
Big
especially
time.
for the MCAT. I think forgive me if I'm wrong on this. Maybe you can fact check me. But I think this idea originated with Marx, and
Yeah.
it's kind of like an intersection with like cars. I feel like this is like a cars passage you could have. It's like
Yeah.
about Marx and social reproduction. Anyway, the idea is, and Marx, like had this idea of like class separation and structure, and like there were the, I guess I don't know like what the terms are, but there's like the upper class, like overlord people that had all the power, and they like
Right.
kept everything for themselves, and then they like put down the working man and et cetera, et cetera. And so Marx's idea was like social reproduction, like the rich stay rich, the powerful stay powerful. They have resources at their disposal, they have connections, they have money. Whereas the poor are kept kind of at their social status because they lack all of those things, right? They lack the social capital, the connections, they lack the resources and the funding that they need to get things done to kind of move themselves pull themselves up by their bootstraps and move themselves vertically in social strata. And again, like there are certainly examples of people who have been able to like pick themselves up from a lower socioeconomic status or social stratum and move themselves to kind of a higher class level. But I think there are lots of examples of individuals and patients that you'll meet who like don't have the resources. And I think about my situation right now. Not that I am like oppressed or like having difficulty with money, because like we have a bright future as future physicians, right? But like my wife is working, and when we moved here we like started looking at daycares, and like
Hmm.
we could barely find we finally found like a church run daycare that was affordable. But like anything other than that, we looked at probably a dozen daycares, and they all are like, you can't make enough money to pay for the childcare, right? And so like it's prohibitively expensive. Like it prevents you from saving any money that you like if you don't have, like a family member or some other way in which you can get your kids watched, then like you can't save any money because it's like it's prohibitively
Right.
expensive. And so like you have to be making greater than a certain amount of money so that you can pay for daycare and so that you can save and so you can spend your energies elsewhere. And I think, that's kind of a maybe frivolous example because it's like so non-consequential for me at the end of the day. Like we're going to make it happen. It's going to be okay because I will be a dermatologist, right? But for millions of people in North America, like this is reality, and
Yeah.
they have these sorts of prohibitions that prevent them from making a jump in social stratum. Like, how would you ever go to? Imagine you're like a young mother of a baby, and you're just out of high school. Like, you're gonna have to take an entry level job somewhere, and you're not gonna be able to go to college. Like, how would you? How would you like have childcare and have a job and pay for college? Like there's not enough time, there's not enough money. And so there
Yeah.
is, I think, something to be said for like this idea of social reproduction, that like people who are wealthy have more resources, they are better able to like keep their status as like high class people.
Hmm.
Um, and the converse is also true that like people kind of like poor, um, what is the terminology that I'm thinking of? It's like poor reproduces poor or something like that. That
Yeah.
like if you don't have the resources, it's just harder. It's harder. Like there are more obstacles for you. And I
Yeah.
think, we see that in our patients, and it again is like an unfortunate situation. We are having kind of these like peripheral to the MCAT, but also like kind of more ethical and social consequential discussions,
Right.
because I think that's what the sociology section is, and like at the end of the day for the MCAT, you need to know the terms, right? You need to know vertical and horizontal mobility. But to be a physician and to be able to discuss these things intelligently, like you need to have some, frame of reference for these things. And
Yeah.
again, I talked about this a little bit earlier, but like we're doing a better job of learning about these things in medical education because they do matter. Like they matter not only for like
Yeah.
quality of life for people, but for health outcomes, for people's ability to, obtain the care that they need and their ability to, um, adhere to treatment regimens, and it matters. Like it makes a difference for people. It's something I
Yeah.
think about a fair amount, probably every day with at least one patient. I'm thinking about kind of social determinants of health and how their situation socially is going to affect their ability
Right.
to move forward with whatever disease process they're dealing with.
Yeah. I think like it is a significant part of patient outcomes, right? Like yeah, it's something that just, you can't make go away. It's something that you have to be mindful of to try to, deliver better care. And it's hard. Like it's not easy. And the message that I really want to try to hammer home, I know we've kind of discussed a lot of the challenges, that are in medicine, but you always will have a platform to do something good, right? And,
Yeah.
Eric,
Yeah.
earlier you alluded to, okay, it may not always be the first thing you reach for, but there's always an option,
Yeah.
right? And so I don't want it to seem like, it's all doom and gloom because it's not. And sometimes I would argue that, getting creative and brainstorming maybe a slightly unorthodox way to help somebody who, wouldn't be a good candidate for plan A or B, is actually the most rewarding part of the job, right? Because it's less straightforward. It feels more rewarding, right? Because this is somebody who likely could not have turned elsewhere or flown across the country and had this $10,000 consultation, right? And I think that's what gets me excited is like this idea of like, okay, this is somebody that we can't help through conventional means. Let's get creative. Let's find a way to make this work. And I think if that describes, the mindset of our listeners, we're in good shape as a society.
Yeah. Yeah, absolutely. I think, seeing someone get better is a beautiful thing. And
Yeah,
all the sweeter if you're like really putting some thought and some effort into
right.
how to help them. And especially because those patients that you're gonna have to put that extra thought and effort into are like some of the more kind of vulnerable patients in our society. And so they need the most help, And I agree with you, Ahmed. Like, we have an ability to make a difference for people and a platform to do so. And as physicians, we're respected within society, and we have a platform to advocate for change too. And so, all things to think about moving forward. And I think, you know, I think I think we need to work together to make things better. But I think there are a lot of opportunities to do good that are available to us right now.
Well said. And to explicitly summarize, the MCAT relevant side of
Yeah.
things, we talked about this process of socialization. We compared and contrasted primary versus secondary socialization. We discussed this concept of mobility, vertical mobility, horizontal mobility. It can be inter between generations or intra within a generation. We talked about this concept of social reproduction that Eric mentioned, which is basically, your social stratum tends to reproduce itself through
Hmm.
generations simply because, if you have resources, you tend to access things that help you acquire more resources, for example, higher education, right? And if you lack resources, you may lack the opportunities to gain resources. Again, higher education being one of them. Um, and, from an ethical standpoint, how that connects to, practicing medicine. And, I think it's a worthwhile endeavor for our listeners. You will hopefully all be future physicians, right? Brainstorm, if you were in a position to be able to advocate, what would that look like? What things do you think you could change to make the healthcare system better? But again, we got to think of, the reality as well, right? Just saying we want to make free care, as great as that sounds, there's a reality behind it, but keep those things in mind and think about what you would do differently because you know I'm a big believer that like everything that's currently in place, not just in medicine but beyond, is the result of an improvement of something else or like a revision of something else,
Hmm.
right? Like, and so what, the policy and infrastructure that's in place now will likely be obsolete 20 years from now, right? And so be a part of that sort of change that hopefully, expands healthcare or creates, more accessibility, breaks down barriers, etc. Um, because I think it's like you mentioned, Eric, it's an opportunity to be an advocate and make, widespread change. And I think, that's one of the things that gets me excited to go to, a clinical skills session or an ethics session where you can start to brainstorm those kinds of things.
We're excited for you guys. Keep up your studying. We're filming this in October, so everyone's got plenty of time to
Yeah.
keep grinding and learning things and getting ready for the test.
And let that be the motivation. We as a society and your future patients are waiting for you. So whenever you feel like you hate the MCAT, just let your love of your future profession
Yeah,
outweigh the hate of the exam.
it's good
And
motivation.
it'll keep you going for sure. But
Yeah.
on that note, we'll wrap up there. We appreciate everybody tuning in and checking out this episode. We hope you enjoyed. As Eric mentioned, keep up the great work with studying, and we'll see you all in the next episode of the Jack Westin MCAT podcast. Take care, everybody.
Bye-bye.